Hello, everyone. Good morning, afternoon, and evening, depending on from where you're joining us today. My name is Abel Ndasho, and I'm the program coordinator for the ANH Academy and the IMANA program. Today, I'm the technical manager for this plenary session on developing guidelines for conducting RCTs in agriculture, nutrition, and health. Thank you very much for taking part in ANH 2020, and welcome to the last day of this year's Academy Week. We look forward to an engaging and interactive session this hour. Afterward, we will see you at one of our 5 thematic sessions at 2:15 p.m. London time, and then at our closing ceremony at 3:15 p.m. London time. Don't forget to take some time during the breaks in the program to explore our poster hall and vote for your favorite poster presentation. You'll find the link in our website on the ANH 2020 poster hall section, but we'll also post the link in the chat box now. Winners will be announced during the closing ceremony later on. A quick reminder that everything that you might need to access the conference material and interactive program can be found on the ANH Academy website at anh-academy.org/ANH2020. Before Shirley Sandberg takes the conversation forward, I have a few technical announcements to ensure our experience is as smooth and interactive as possible. Please introduce yourself using the chat function. Let us know your name, where you're joining us from, and the organization you work with. You can access the chat box by clicking the chat button at the bottom of your Zoom window. When you send messages in the chat box, be sure to click all panelists and attendees instead of all panelists. This way, your message will reach everyone who is in the session. You will have the opportunity to submit your questions to today's panelists by typing your questions into the chat box in the Zoom panel. You may send in your question at any time during the session. We will collect them and we will do our best to address them during the Q&A time. If we have time, we may ask participants to raise their hands so that they can ask their questions using the audio function. Throughout this session and today, please get involved in the ANH 2020 conversation on social media by using the conference hashtag ANH2020. Finally, if at any point you experience technical issues, please check your audio setting and your internet connection. If lost, please try to connect using the same link and password. If you have a technical problem, please send me a private message using the chat box. I think that's it from me. Over to you, Shelley.
Good morning, good afternoon, good evening, and thank you for joining our ANH plenary session. My name is Shelley Sandberg. I'm with the Bill and Melinda Gates Foundation in Seattle. We see an increasing number of randomized controlled trials being used to assess the impact of food systems interventions on agricultural, nutrition, and health outcomes. Last year in Hyderabad, we began to discuss some of the methodological issues that arise in the design, implementation, and analysis of these complex trials. And we've continued to work to further characterize these issues, seeking input from researchers from a wide variety of disciplines, including statistics, epidemiology, economics, and nutrition. Here to present this ongoing work so that we can get your input, and we will have plenty of opportunity for discussion, are Jeff Leroy, Senior Research Fellow at the International Food Policy Research Institute, and Ed Frangillo, Professor of Global Nutrition and Health at the University of South Carolina. Over to you, Jeff, to begin.
Hello, everybody, and good morning, good day, good evening, depending on where you are. Thank you for joining the session today. We're very excited to have you. As Shelley pointed out already in the introduction, RCTs, randomized controlled trials, are increasingly used to evaluate the effectiveness of interventions, complex interventions, such as the ones we conduct in agriculture, nutrition, and health, ANH for short. ANH trials are different from simple efficacy trials. In complex ANH trials, we're typically interested in learning what did and did not work, and not just if it worked. We also estimate effects on a range of outcomes, and these could be as diverse as agriculture productivity, nutritional status, and women's empowerment. And the importance of what we do is not just in the endpoints of what we're interested in, but also in understanding the underlying mechanisms by documenting effects on a number of intermediate outcomes. So that these characteristics immediately show that limiting the number of outcomes we measure, as is done in drug trials, runs the risk of missing important results. So the special characteristics of ANH trials lead to questions and confusion about several topics. And 3 topics we want to discuss today include primary and secondary outcomes, what should be the total number, and what kind of causal inference can we obtain from these outcomes. Another issue relates to multiplicity. Typically in the studies we conduct, we have a large number of comparisons that we can make. And the third topic relates to the analysis we conduct. And here we will be talking about intent to treat versus per protocol analysis. In an attempt to reduce the confusion and to bring some clarity, we have been working on draft guidance to conduct ANH RCTs. And the objective of this specific session today is to present issues that relate to conducting these trials, and also to present to you the draft guidance as it relates to these 3 topics. We're presenting this for discussion, which means that we would like you to send us questions, feedback, to comment on what we present. We strongly encourage everybody to post questions and comments in the Zoom chat box. And we assure you that even if your question is not addressed today during the session, the comments will be looked at when we continue to work on refining this guidance. So today's session will be organized as follows. As I already told you, there are 3 topics we would like to discuss with you. The first one is related to primary and secondary outcomes. The second one relates to multiplicity, and the third one to the type of analysis. We will have very brief presentations on each of these 3 topics, and then after each topic is presented, we will leave about 10 minutes of time for question and answers and for feedback. So on to the first topic, and that one relates to primary and secondary outcomes. So what are the issues here? Well, first of all, let's quickly look at the guidance, the existing guidance from Consort and from the Food and Drug Administration. So the guidance we currently have is that primary outcomes preferably are limited to 1, and those are the outcomes that is the outcome we use to calculate the sample size of the trial. With respect to secondary outcomes, the guidance is that we should only have a limited number of these. And what's important that for all outcomes, irrespective of whether they're primary or secondary, they should be pre-specified. Now, as we've discussed already, ANH trials typically seek to document impact on a wide range of outcomes. So this guidance doesn't work particularly well for the work we do. So what are the issues then? Well, what is the definition of a primary and a secondary outcome? How many primary and secondary outcomes are acceptable, and which type of inference can be drawn from each type of outcome? So we have drafted some recommendations related to this topic, and it goes as follows. With respect to primary outcomes, we believe they should be defined for each major construct that is being studied or evaluated in the trial. And these constructs should include both the trial endpoints and the outcomes along the program impact paths. For each primary outcome, sample size and power calculations should be conducted to make sure that the trial is sufficiently powered to detect meaningful differences or impacts. And when it comes to primary outcomes, the results of the testing will lead to confirmatory findings. In the selection of the primary outcomes, we should make sure that the outcomes are scientifically relevant and relevant for programs and policy. What then is the definition of secondary outcomes? Well, we propose that all outcomes not included under the primary category are secondary outcomes, and that any findings or conclusions as they relate to secondary outcomes should only be understood as exploratory. Now, this is the last slide on this topic of primary and secondary outcomes, and here we provide some discussion topics to get us started on the discussion. Questions relate to the definition of primary and secondary outcomes. How are these two conceptually different? Are inferences about secondary outcomes always exploratory? And if not, how are they different from primary outcomes? Is there a reasonable maximum number of primary and secondary outcomes a trial can have? If outcomes are defined by construct, should there be a recommended limit to the number of outcomes per construct or to the number of constructs per trial? And then finally, should the findings on all primary outcomes be reported in one and the same manuscript? These are just some discussion topics. We strongly encourage you to not stick to what we have on the slide and to let us know if you have other questions and topics. And I now turn it over to Shelley to get us started on the discussion.
Thanks very much, Jeff. So please add your questions into the chat box, and we have about 10 minutes now for discussion of the topic of primary and secondary outcomes. So far, I'm not seeing any questions. So here's one. This is from Sunita. Sunita, do you want to go ahead and ask it yourself?
Yeah, sure. Just quickly, if you have multiple outcomes, it seems sensible to have for different domains, different primary outcomes. And if we call them that, and if we, well, but regardless of what we call, there will be a need for multiple testing. And if we do that and include that, then I'm just wondering if we'll end up having to deal with much larger sample sizes and end up shooting ourselves in the foot a bit. So I'm interested. I'm obviously statistically, I'm not that strong. I work with statisticians, so I just thought I'll put it up there. Yeah, considering we're just finalizing a manuscript on this topic. Thank you.
I can start, and I'd be happy for Ed, but I think here we can be fairly quick because the next topic we want to address in this panel discussion relates to multiplicity and the need or the need and the risks of correcting for it in the statistical analysis. So if it's okay, I would propose that we wait for the next discussion block to address this issue.
Inge Brouwer, do you want to ask your question? If you're not able to, I can ask it. I see it in the chat box. Okay. Inge Brouwer asks, are outcomes always quantitative? So qualitative outcomes are always secondary outcomes? That's a question.
Good question. I have never conducted a trial where we have qualitative outcomes listed under the trial outcomes. We do include qualitative research in our process evaluation and implementation study that mostly accompany the trials we conduct. But I've never had qualitative outcomes strictly linked to the trial itself. Ed, would you like to comment on that as well?
Yeah, I agree. I haven't really encountered that situation. I mean, I think one of the challenges is that if the qualitative outcomes are generated during the course of the study, then it's hard to be specifying those a priori, although, I mean, that depends upon when the statistical analysis plan is finalized and signed before the analysis.
Maybe I can explain. I was asking this because when you move towards more measuring consumer aspirations, for example, or consumer motives, probably you go more towards qualitative indicators. They may be quantitative in numbers, but actually their character is qualitative.
But if they're measured on you know, the study population, even if they're in nature, and we probably don't have enough time to kind of have an in-depth discussion on this. But if they're part of the set of outcomes, even and they're somehow quantified, I do not see why they couldn't be part of the set of primary outcomes of the trial.
Okay, let's move on. We have a lot of questions now. So several people have asked a question: can we include multiple primary outcomes in a hypothesis statement? Is that possible to do?
Ed, do you want to address that?
Well, I think that's in a way, the crux of the issue is, I think we want to say for agriculture, nutrition, health trials and similar complex trials that the answer should be yes, that there should be multiple primary outcomes, because there's multiple constructs that are important and potentially equally important when there are inputs into the interventions that are coming from multiple sectors. Each of those sectors has obviously an interest in whether their component of the interventions is making a contribution. So I think that's what we're grappling with, is exactly that question. But we believe, yes, there should be the opportunity to specify multiple primary outcomes with hypotheses.
Okay. Will, you have a question. Do you want to ask Will Masters? Okay, I'll go ahead and ask it. Should we focus, Will asks, should we focus on primary outcomes for which we can afford sufficient power, big expected effect, small background variance, versus more ambitious things for which we may be insufficiently powered?
So, I mean, we're still refining our thinking on this, but I believe that an important criterion for a primary outcome, it's not just conducting a power calculation, but having that and ensuring that the trial is sufficiently powered to detect a meaningful effect, and meaningful means that it's relevant for programs and policy. To me, that's an important criterion to list it under primary outcomes. The reason is that if we do not find an effect on that specific outcome, then if we're not sufficiently powered, it is impossible to say whether the lack of an impact is due to not having the power to detect that impact, or whether the trial did not manage to change that outcome. And it's not very informative if we can't make that distinction at the end of the day.
I would just add that in my experience, that it's often the case that one outcome is more demanding of sample size to have adequate power than the others, particularly if they're, for example, binary outcomes, like whether or not someone has a health condition. So in a trial we're just analyzing now, the primary outcome is whether or not people had their HIV, whether the virus was suppressed or not. Well, binary outcomes require a larger sample size. So if in that case, the trial was powered for that outcome, which we confirmed had adequate power then for just about everything else.
Okay. Several people have some form of this question, so I'll go ahead and read it. Is an output the same as an outcome? If not, what is the difference? Can you give some examples? So understanding better the definition of outcomes.
I've had long discussions about this, and I may not be the best, because I feel like everybody has their own definition about what an output is, and an impact, and then an outcome. To me, an output, and this is just popping up in my head, would be something as the number of farmers you have trained in your program. That's an interesting thing to know, but that is not something we would be excited about when we want to assess whether something worked or not, or how it worked. So this would be, to me, that would never qualify as an outcome. To me, an outcome would be more related to did practices of these farmers improve? Did their knowledge improve, and so on? So that to me would be the distinction. But again, I'm not a specialist in that fine language of outputs, impacts, and outcomes.
Ed, do you want to add anything?
No, that's good. Yeah.
Okay. Next question's from Isabella Mazzarera. Isabella, do you want to ask your question?
Sure, thanks, Shelley. So my question is, if you have intermediary outcomes and a final outcome, for example, if the final outcome is nutritional status, usually we think we don't have enough power, or maybe some studies are not likely to find an effect, but could you also look at intermediary outcomes together with the final outcome as primary outcomes concurrently? Thanks.
I think this is a very important question, and a point we would like to emphasize that in the type of studies we do, just measuring the endpoints in your example, nutritional status, is not satisfactory because we miss out on a lot of important learning. So if things, depending on the intervention, if you believe that impact on nutritional status will operate through improved food security or improved production or improved consumption, then we should be measuring these outcomes as well. And if the study is sufficiently powered to detect impacts on those outcomes, I think they could also be listed under the primary outcomes of the trial. A very quick addition, sometimes it is useful to measure outcomes even if the study is not powered to do. Mortality, for instance, is an outcome that typically studies are not powered to detect differences in. But when studies are pooled and meta-analysis are conducted, that outcome becomes relevant. So sometimes it does make sense to include outcomes even if the study in and of itself is not powered sufficiently. But that would be, for that specific study, would be a secondary outcome, I believe.
Okay, thank you. This is going to be the last question in this section, and we have a lot more questions. So thank you very much for submitting those, and they will definitely be looked at and considered, as Jeff mentioned. So several people have asked a form of this question. Wouldn't the primary outcome vary based on the stakeholder? For example, a primary outcome for mothers might be different from the primary outcome for their children. Can we have different outcomes per sector?
Ed, I feel like I'm answering all questions. Do you want to address this one, or should I keep going?
No, you can keep going, Jeff.
Okay, good. Yes, you can call it sectors. In our writing, we've called it constructs, and I think it's similar. And by all means, we can have different primary outcomes per domain or sector or construct. And I think that is important. In the way I think as a nutritionist, poverty and food security tend to be intermediary variables, but for other people, those are very important endpoints. So depending on your perspective, you will have put different weight on different outcomes and variables. But again, repeating that many of the outcomes that are in the paths of the impact paths should and could also be considered primary outcomes.
And what about
Yeah, just to add to that, I mean, I think this links to the previous question also. I mean, what's exciting about the science that is being conducted by this community of people is the recognition of the importance of looking at not just where do you end up in the end, but how did you get there? And so prioritizing having outcomes that are sufficiently powered along the impact paths is really important. For a long time, for example, we tended to focus on child outcomes without worrying too much about what the effects were on the mothers, and obviously that doesn't really make sense. So you know, absolutely, we should be striving to do that.
Okay, thank you very much for all your questions, and sorry that we didn't get to them all, but at least we got to answer several. Jeff, Ed, sorry, why don't you go on to the next topic now?
Okay, so Sunitha already raised a question about this. So multiplicity refers to when trials have more than 2 intervention arms or have multiple outcomes of interest or conduct subgroup analyses. And so when that happens, the number of tests or evaluations that can be done can be large. And so this multiple comparisons or multiplicity issue can occur because we're trying to make statistical inferences together simultaneously. And the concern that people have is that if you're doing many tests, then that can increase the type 1 error. That is, by chance, you can conclude that based on a test that the intervention had an impact on some outcome when in reality it had no effect. So the issues that arise from this are, I mean, the guidance, the Consort and FDA provide reporting guidance, and there they say, try to avoid situations that give rise to multiplicity, but still it's common in ANH trials for 3 reasons. One, we have multiple outcomes as we just discussed. There's often multiple intervention arms, not just a comparison in 1 intervention arm, but more intervention arms. And we're interested in subgroup comparisons. Did the intervention components work better for certain age groups versus others, or for males versus females, for example? And so some issues that arise are confusions about the different types and origins of the multiplicity, confusion about when is adjustment required, is it recommended, is it wrong to do it? There's a lot of conflicting advice in the literature about that. And then recognizing that if we do adjustment procedures, which tend to be rather conservative to preserve type 1 error rates, we will increase the type 2 error rate, meaning that if there's a true impact, we may not detect it. And so in our draft recommendations, we differentiate these 3 situations, and for multiple arms, suggest using pre-planned a priori contrasts or post hoc multiple comparison procedures that are efficient, such as Tukey's test if you wanted to look at all possible pairs. For multiple outcomes, to limit the number of primary outcomes when the trial is designed, although we've just discussed that we don't want to limit it too much, and then testing a limited number of primary outcomes that are stated a priori so that those can be deemed confirmatory with others deemed exploratory. And then for subgroup analyses, if they can be specified a priori, that's great, and have hypotheses about those, so those are confirmatory, but then otherwise they would be seen as exploratory. And so some discussion topics is, well, is this an issue? For multiple arms, is this an issue? And at what number of arms do you start needing to make these adjustments? For multiple outcomes, is multiplicity an issue for primary outcomes? And if so, how many primary outcomes sort of trigger the need to do it? And the same for secondary outcomes. Should adjustments be made separately for primary outcomes and then for secondary outcomes, or should they all mush together? And are adjustments needed for additional outcomes that were not registered before the trial and so therefore would clearly usually be considered exploratory? And then for subgroup analyses, is it an issue here? What adjustments should be made? Do you have to worry about it when they're a priori? And are the adjustments different if the subgroups analyses were planned a priori? So those are some questions that we're grappling with, but we welcome your questions or comments.
Thank you, Ed. The questions are starting to come in. I'll ask one of the first ones. Can you explain multiplicity with the help of an example?
I'm sorry, multiplicity and?
Can you explain the concept of multiplicity with the help of an example?
Oh, okay.
Give an example.
So, well, for an example of multiple arms is a trial that Jeff and colleagues led in Guatemala where there, I don't remember now, Jeff, 6 arms that were comparing different combinations of different food supplements as well as some of the other components in the trial. So that would be an example of multiple arms. For multiple outcomes, I think it's obvious that when we have outcomes corresponding to constructs for different components of the intervention, then then that could involve a measure of maternal well-being, for example, maybe a woman's iron status, whereas we're also interested in the child's iron status and how the child was fed. And we might also be interested in whether or not people have received or sought adequate antenatal care, for example. And then for subgroup analyses, I think this arises most often when we either suspect ahead of time that certain groups will benefit more. For example, giving advice to mothers about how to feed their children may not work very well if there actually isn't sufficient food available. So food security may be a modifier of that and therefore would trigger a subgroup analysis based on that.
Okay, thank you. Anne-Marie, you have a question. Would you like to ask it? Okay. She said, I see a tension between getting the science right on the one hand, and on the other hand, having flexible and context-specific interventions where people can decide what intervention they like. Any comment on that?
I'm not sure I understand the question perfectly well, but I think what's very important and kind of an important principle for this topic is that we do not want to encourage people just reporting on what turns out to be statistically significant. So when we conduct these trials, we look at many different outcomes, we potentially have many different arms, and we need to be transparent, which means that when we plan the study, we need to tell the world that this is what we will do, these are the outcomes we plan to collect, and these are the comparisons we plan to make. And then we should be reporting on all of these outcomes. If we kind of just report on what turns out to look good, then we're kind of cheating ourselves and also not helping others because we're selective in what we report on. So we kind of reduce the amount of learning that can be obtained.
I think I might have unmuted by now. What I want to say is it's not really the outcomes, it's more a case of giving communities some kind of autonomy to decide which of all the interventions that they want. And if you're working across the sectors, trying to do lots of multiple things according to the context. So by definition, almost, your different intervention arms are going to need to have different things going on according to the context. And your randomization becomes difficult. So I think what I mean by the tension is getting the science right versus having a very sort of flexible program.
I think this comment is important because we do want to, if possible, end up with some generalizable scientific findings that others can use. On the other hand, in a particular context, we want to be responsive to the stakeholders and communities who we hope will benefit from the work that we're doing in that location. And that's part of the reason why we end up with a situation where we have multiple competing interests and therefore multiple evaluations that we need to think about how to handle. And that's why this issue comes up.
Okay, thank you. We have a question from Helen Harris Fry. I'll ask it. I think the subgroup, she said, should all be planned and specified in a protocol. Deviations from the protocol should be justified. For example, if something unexpected came up, like exposure to COVID-19. So I guess that's more of a comment. I don't know if you have anything to respond, Ed or Jeff.
Well, I think the thrust of the consort guidance, which is wonderful, is about transparency, as Jeff said before. It's about doing as much as you can up front to say what you're intending to do so that then people can evaluate the results against that. So absolutely, I would agree that to the extent possible, subgroup analyses should be pre-planned and specified in a protocol. We know, though, that circumstances come up, as Helen mentioned, like COVID, or others, things that we've learned along the way where we realize that there's a dependency potentially on something that we didn't even realize existed, or something that occurred. In our Kenya study, for example, there were hippopotamus that were running all over the fields at one point that wasn't particularly expected. So that was a potential modifier of effects. So yes, specify what we can up front, and then be transparent when we've gone away from that because of something we've learned along the way.
Okay. This is a question from Betta Orino. Should we correct for multiple hypothesis testing when we have multiple outcomes, including if we have them pre-specified?
That is exactly the question that we and others are grappling with, and there's honestly different views about that. I mean, mine, for a long time, I've thought about this for a long time, and mine is that adjustments for multiplicity are never helpful. They're always make things worse, and what we should do is just be very transparent about it. But that is not a majority view, and there's other strong views that adjustments are required. So we're trying to find the middle ground here.
I do think it makes sense to go back to the objective of the trials we conduct. I've never come across a situation where we set up a study and we say, we're interested in these 10 different outcomes, which could be child nutritional status and diet and egg productivity and empowerment and whatnot. And we will call it a success if at least one of these outcomes is statistically significant. That would require correcting for multiple hypothesis testing if we thought about studies this way, but that's not how we do it. At the end of a trial like this, we will say, look, this trial was successful in improving this and this outcome, and these outcomes did not change. And because we measured many intermediary variables, we think this is what happened, kind of the flow stopped at this outcome. So by thinking it through and using theory to come up with the research questions ahead of time, I'm also inclined to think that adjustments are not needed, because we go into these trials with a lot of prior thinking. We're not kind of blind to what we are hoping to test and to find.
Right, and so the plausibility of inferences depends not just on the analysis of the outcomes, but does the whole story make sense along the program impact paths?
Okay, thank you. This is the last question for this section, and thank you again for all the questions you've submitted. This is from Mohammed Hassan. Do factorial designs in particular suffer from multiplicity problems?
Well, yes. I mean, R.A. Fisher, for example, invented factorial designs because he thought it was really crazy that people were testing only one thing at a time in a trial. So, having a factorial design, it can be a very efficient way of going about things. And so there's sort of standards of practice that have been around for decades for how to handle analyses in those trials. But a factorial design, you know, if you have a 2x2 factorial design, that's really the same as a one-way factorial with 4 groups. So thinking about it in a factorial way is helpful to us, but it doesn't really change that in a 2x2 factorial, there's potentially 4 groups that we want to compare.
Okay. Jeff, do you want to add anything?
No.
Okay. Thank you for all your questions. Sorry that we were not able to get to them all. Ed, over to you for the third topic, analysis.
Okay, so here we're just thinking about the type of analysis, and the standard has been to do an intent to treat analysis, which includes all individuals in the trial that are in the study arms to which they were assigned, regardless of, in the intervention, whether the extent to which they actually participated in the intervention or were exposed to the intervention, because this has the lowest risk of selection bias. An alternative in the literature is what's called a per protocol analysis, which has many other names. And here the protocol refers to the protocol for the intervention, not for the data collection. That in a per protocol analysis, one restricts to those who fully participated in the intervention, with the idea that it's those people that we would get to see whether there's really a potential for an effect. But the problem is there's a high probability of selection bias because the people who choose to fully participate may be different than the people who do not. And then in the literature, there's other labels, modified intent to treat and modified per protocol, which are intended to be in between these two. So some issues that arise from this are, first of all, the guidance from Consort is that it's not important to label the analysis and figure out which label actually applies. What is important is that there's very clear, detailed description of exactly what was done in the analysis so that readers can judge how the analysis was done. We know that limited participation in the intervention package is common in ANH trials. It may be that there's full participation in certain kinds of training, but not other kinds of training, or that people hear mass media messages but didn't participate in the counseling or something like that. And so some issues that arise are confusions about these different types of analyses because the literature is confusing. Complete data at endpoint are rarely available for all individuals in an ANH trial, especially if they've been followed over time. And that full participation is difficult to define often in ANH trials. So some recommendations are, not surprisingly, that an intent to treat analysis should always be reported because it takes advantage of the random allocation and is thus least prone to selection bias. That the results provide strong evidence of effectiveness, even though we know it's an underestimate of what the efficacy would have been had everybody fully participated. And that it reflects what policymakers, funders, and program implementers can reasonably expect the population impact to be on average when it's put out there in the real world. A per protocol analysis requires prior specification of what's meant by full participation, which might be difficult. This analysis can be helpful, but only in a sort of augmenting way because it produces biased estimates and should only ever be presented alongside an intent to treat analysis. So some questions for discussion are first of all, if we go back to Pocock's 1983 classic book, for example, he defines intent to treat as all eligible patients or participants, regardless of compliance with the protocol, should be included in the analysis whenever possible. But some other definitions have come along which add some other criteria about not having missing information or having outcomes at the end line. So what really do we mean by intent to treat? And is the definition that includes these additional criteria even useful since it's practically impossible to attain? And then another question might be, well, what happens when we are missing data on a particular outcome of interest at end line? Do we try to impute that, or how do we handle that situation? So I'm sure there's other questions, so why don't we open it up for your comments and discussion.
Thank you, Ed. Yes, the questions are already coming in. Talia, if you're able to unmute, it'd be great if you could ask your question.
Sure. I just have never actually seen a complex ANH trial where it's really clear who participated fully. And we're often working along these complex pathways where there are lots of different levels of participation. So I can't really, I can imagine that there might be justification for some exclusions based on migration or basically no participation at all, but as long as it was considered and justified, and but I in terms of real world situations and effectiveness trials, shouldn't we really, I can't imagine that per protocol analysis should ever be the primary reporting mechanism. But I would say it must be very important to do sub-analyses on different aspects of participation. Thank you.
Thank you.
Yeah, thank you for your comments, Talia. I think we would agree completely with what you said. I think that what I see happening, I mean, there are circumstances and trials that in which I've been involved where it made sense to do some kind of per protocol analysis because coverage was simply not what we were hoping for in a particular place, and that wasn't, in a sense, anything to do with the participants. That had to do with the rollout of the intervention itself. And so having that extra information gave us some extra insight. But I agree in general that we really have to rely on the intention to treat analysis because it's difficult to even specify what the alternative would be.
Great. And I just wanted to share that there are comments in the chat box about people being concerned that there's a focus on being seen as successful and that it's important to report null results, and getting to the issue that needing to pre-specify those outcomes and then report them all in one paper regardless of the result.
Yeah, and I just want to, if we created, or I created the impression that we only care about significant results, that's definitely not what we want to say. We should be, whether it's a null result or not, it's important to report on it. And being transparent as what you're measuring, what you're powered to detect, and then what the findings are is incredibly important. So I completely agree with those comments.
Great. A new question from Naomi Saville. It always feels like cheating. Almost feels like cheating to impute a primary outcome to me. Could it really be justified?
To impute a primary outcome?
Mm-hmm.
Ed, this would be for you, but it looks like you're muted. Okay.
Yeah, I think, well, I think this is a bit of a tricky issue in a way. It partly depends upon how the analysis is done. One of the advantages of doing a sort of mixed model kind of analysis is that under the assumption of missingness at random, then one doesn't have to explicitly impute primary outcomes that are missing. I think that my own view of it is that for the reasons you've said, Naomi, that it's probably best avoided. It's hard to think about a circumstance where one would feel really good about imputing in an explicit way the primary outcome.
Great, thank you. B. Rogers, are you able to ask your question?
You tell me, can you hear me?
Yep.
Yeah, well, it seems to me that yes, you always have to do intention to treat. And it seems to me also that you have to do per protocol because you're asking two different questions. One is the effectiveness question. You know, we throw this out there and what's the result? And then you need to know what determines who participated. And then you'd need to know if they participated, did it work? Because it's going to be really different if it worked really well for 3% or it worked really well for 90% of the people who actually participated. And why they participated, what's the selection bias, would seem to be critical.
I agree with that comment.
Yeah, thanks, B. But I just want to emphasize a difference between what B is saying and what might otherwise be done. As I understand it, B is saying we need to really understand how what we see in the outcomes is related to the participation, and then back up further, what determined the participation. So we really understand all of that. And absolutely, we should be striving to do that. That's different than basing a judgment about whether the intervention is successful in some sense solely on a per protocol analysis.
Yeah, but I guess, I guess what I'm saying is it successful is a narrow piece of the question that we should be asking.
Yes, and we're agreeing. We're trying to agree with you, B.
Agrees violently. Yep.
Okay. Thank you, B. I have a question from Kate Schneider, and I'm going to ask it in the interest of time here. She asks, how do you reconcile the different vocabulary and disciplinary approaches to analysis? Do you have examples of how this has worked in an interdisciplinary team? Specifically, she asked, between epidemiologists and economists on what's the appropriate analysis?
Well, this is exactly why in the concert guidance, they basically throw up their hands and say, just describe what you did. Because different people use different labels. I mean, I really think, and I see this in some work with some colleagues, that they really want to do some kind of per protocol analysis, but they don't want to call it that because they know that people don't like that label. So they want to call it a modified intent to treat, and that's kind of beside the point. Yes, we need to communicate with each other, and the best way to do that is to just focus on exactly what's being done and what are the best decisions we can make, and not worry about the labels.
Okay, thank you. Last question in this section is from Laura Hackle. How should we deal with missing data because of loss to follow-up versus missing data that comes because the measurement was below a certain threshold?
Well, I mean, if we have outcomes that are missing because they go below a certain threshold, then we have analysis techniques like Tobit models or variations of that can handle that kind of censoring. I think another issue that comes up is, sporadic missing data because somebody answered, I don't know, 12 items out of 14 in a scale, but for some reason didn't answer 2 of them. We don't want to lose that information, so some form of imputation can help there. That's different than attrition or loss to follow-up. I think one of the things that we probably need to talk about more in our draft guidance is there are techniques available for at least examining whether it's possible that there was differential attrition across the arms and whether that differential attrition might have caused bias. That should certainly be done along with the main analyses, and there's potentially ways of doing some adjustment if we do think there's some bias being introduced. So that's an important question and deserves a sort of a fuller discussion.
Thank you, and thank you, Laura, for your question. Several people, I'm going to ask just one more question that goes across all the topics because several people have had some form of this question, and I also see people adding specific references to the chat box, so thank you for that. People have observed that agriculture, nutrition, health is not the only field that has complex trials. Can you recommend literature on complex interventions and their evaluations from other sectors? What is unique about ANH, or should we think of it as unique?
Let me start, and then I'm happy for Ed to add to this. This is a comment we've shared our draft guidance with a number of colleagues, and this is something that has come back as a comment. For me, the answer is that we're not unique in ANH in the type of trials we do with multiple inputs and multiple outcomes across many different domains that we want to observe. Why we focus on ANH is because that happens to be the field we're working in. And so we have experience with conducting these trials. We are familiar with the outcomes, with the people who conduct them, with the organizations that implement these trials. So that's why we feel that we can contribute something. So that's, for me, the focus, where the focus on ANH comes from. It's not because we feel we're different from other areas that are conducting complex studies as well.
No, I agree. I think our intent from the beginning was to try to do something that would be helpful to this community of people, but certainly there's other communities of scholars who are struggling with some of the same issues, for sure.
Okay.
And if anyone knows of guidance from those other communities of scholars, that would be really helpful.
Yes, please let us know.
Great. Ed or Jeff, over to you for the wrap up. Thank you to everybody for all your questions. Sorry we weren't able to get to them all, but thanks for the very robust discussion.
So we didn't really agree on who would talk through this very long last slide, so I'll take the lead here. We want to really thank you for being with us today and engaging in giving us lots more to think about, to ask your questions. Those are very good. Everything that you left for us in the chat box will be looked at. So even if your questions were not addressed directly, we only had 1 hour. We will definitely look at what was submitted. And then your comments, combined with comments from a group of experts from many different disciplines that we've shared the draft document with, will be used to finalize this guidance. And then hopefully later this year, I would expect we can put this out and share with everybody. Ed, did you want to add anything to that, or Shelley?
No, thank you. Just thank you very much. And all three of us are easy to find. So if you have any thoughts further to share, or suggestions or literature that might be helpful, you know, please do contact us. I mean, our goal in the end is to produce something that will help all of us in this community of scientists to do the best work we can going forward.
Great. Thank you, everybody, for the very rich engagement. We really appreciate your inputs, and I think the discussion will continue, as Ed and Jeff said. Thank you.
Thank you.
Thanks.
Thanks all, and please join us in one of the 5 thematic parallel sessions happening in 15 minutes, and also at our closing ceremony at 3:15 p.m. London time. I'll end the call now. Thank you.